Let me to start my presentation on evaluation and management of snakebite envenoming insight from peripheral healthcare setting. No conflicts of interest to declare for this presentation. And objectives of today's presentation, I have two parts. The first half of the presentation is on snakebite envenoming insight from peripheral healthcare settings. I try to discuss my experiences at peripheral hospitals where I work, Deniya and Mahyanganaya. And the second part of this presentation is snake identification, clinical evaluation, management and prevention of snakebite envenoming. Snakebite envenoming insight from peripheral healthcare setting. Overview. I discuss 4 interesting case scenarios of snakebite envenoming. Then briefly discuss 3 studies which we have done at Peripheral Hospital, Deniya and Mahyanganaya. The first study on green pit viper envenoming, and the second study is on hump nose pit viper bite envenoming, and the last study on snakebite envenoming in Mahyanganaya. Let me just start with this case scenario. Severe envenoming after Russell's viper bite. Our patient was 39-year-old lady from Kolongoda. She was bitten by a snake while she was collecting vegetables to prepare her lunch and admitted to base hospital Mahyanganaya. She was collapsed in 30 minutes after the incident at the ETU, and we resuscitated the patient. However, patient developed severe circulatory collapse, neurotoxicity, nephrotoxicity, and incoagulable blood, and patient was admitted to ICU. However, the patient succumbed to her illness and died after a few hours despite maximum medical care, and she was given antivenom as well. This is the snake this is the offending snake brought by her husband, and I am sure everybody in this audience can identify this snake. Triangular head, short tail, and you can see inverted V mark on the head, and 3 rows of the patches, longitudinal patches on the body. So this is Russell's viper. So any medical officer can identify this snake. And this is the ventral surface of the snake, and you can see abdomen is abnormally distended. So there should be solid prey, or maybe gravid uterus, or maybe any other pathological lesions in the abdomen. So we dissected this specimen and took this partially digested mouse out. And I would like to thank one of my house officers, Chintaka Pittikalarachi, who has taken all photographs and dissection. And also, you can see the picture on the right-hand side of patient, and there is bleeding from the puncture site. So we went ahead and did autopsy. And you can see over the bite side, there is bleeding. And you can see all major organs, heart, brain, and kidneys, all major internal organs were normal. And we did histological examination. You can see the liver and kidney, which were normal, and lungs. You can see heavily infiltrated neutrophils in the lung. So we discussed with our JMO. I would like to thank again JMO. He helped a lot. He did this autopsy, and there of Mahyanganaya Base Hospital. Then what is the lesson to learn from this case? Sudden death is a potential complication of snakebite envenoming. So any patients come to you after snakebite, we have to observe the patient for the envenoming signs, and then we have to start antivenom as early as possible, because there is possibility of sudden death after snakebite envenoming. This is the second case, a venomous snakebite, no envenoming signs. Our patient was 15-year-old schoolboy from Diula Palace, was bitten by a crate at 7:45 p.m. while he was sitting on a chair. Patient was totally asymptomatic, and we observed 48 hours and no any symptoms of local or systemic envenomation. You can see the snake brought by the relatives, and again, no difficulty of identifying the snake. You can see white paired rings on black background and oval shaped head. So also you can see this, the subcords are not divided, uniserial subcord. So this is a common trait. So what is the lesson to learn from this case? Victims of deadly venomous snake bite can present without symptoms and signs of envenoming. AVS should be commenced if indicated only. So we are not going to give antivenom for patients who are coming with even venomous snake bite, because there should be systemic envenomation except cobra. I will discuss one case also. So we have to carefully follow the patient and see whether there is systemic envenomation, and then we can start antivenom therapy. This is the third case, severe anaphylaxis after antivenom serum treatment. Our patient was 28-year-old gentleman from Hettipola having bronchial asthma, presented to base hospital Mayanganaya after snake bite envenoming. He developed severe neurotoxicity and incoagulable blood. So this is a case of Russell viper bite, and we started antivenom serum immediately, but patient developed severe anaphylaxis after antivenom therapy. So we managed this patient for anaphylaxis. Patient recovered. We have to continue antivenom. So we restart antivenom, but again patient develops severe anaphylaxis. So we can't continue antivenom. So what we can do? Patient, what can we do? The patient was severely envenomed. Patient is always getting the anaphylaxis with antivenom therapy. At that time, unfortunately, ICU bed also not available. So we anyway observe patient in the night, and I discussed with the experts of this area. Actually, I contacted Professor Gampola, and he told me, you can give hydrocortisone. We gave hydrocortisone to the patient 400 and observe for another 6 hours, because hydrocortisone works after 6 hours. So we gave, but we were ready to intubate patient. Patient developed respiratory distress. And fortunately, patient was envenomate, neurotoxicity and vascular toxin was there, but not developed respiratory distress. So we gave hydrocortisone and observed for 6 hours, and we restart antivenom serum, and patient had no any symptoms of anaphylaxis at the end of the 6 hours. So very useful, management what we can do, right? And then another dose of antivenom also we repeated after 6 hours. Because 20 WBCT was prolonged, Russell viper can cause prolonged WCT. So no anaphylaxis or even allergic reactions at that time. So the patient made a complete recovery with no complications. And AVS can be started 6 hours after IV hydrocortisone if victim develops severe anaphylaxis or severe allergic reactions. That is one of another interesting case. How can we manage severe anaphylaxis? But we should be ready for the ICU management and sometimes need intubation. And this is the fourth case I'm going to discuss. This patient was admitted after cobra bite. Patient is still in the ward in Gampola, and last Sunday patient was admitted to our ward. The patient was 28-year-old lady. She was bitten by a cobra when she was working in tea plantation at Galatha. It's close to the Gampola, and admitted to the base hospital Gampola. She had severe pain and developed bluish discoloration, and later she developed gangrene over the bite site and no features of systemic envenomation. AVS given because there is indication to give antivenom for the local reaction after cobra bite. And now we did wound debridement, and you can see the first picture on the left hand side, half an hour after this incident, and bluish discoloration with the local toxicity. And the second picture is after 18 hours. You can see the bluish discoloration, gangrenous leg plus blister formation. So patient is having severe local toxicity. And now patient is recovering. And what is the lesson to learn from this case? AVS should be administered for cobra bite with local envenoming. We can't wait for the systemic envenomation for the cobra bite. We can give antivenom for patients who is coming with the cobra bite with the local envenoming. And people who work in tea plantation, there's some facts for the community we have to educate. People who are working in tea plantation can use appropriate shoes or boots to prevent snake bite. You all know. So basically tea lands, the bushes are joined together. So people are walking, we can't see the ground. So there may be snakes and you can get bite. So if people use boots or at least appropriate shoes, so that is the only way of prevention of snake bite. People are working in tea lands. A lot of the things we can learn if you study this incidence of snake bite. And let me discuss few studies which we have done at Peripheral Hospital. So this is on Sri Lankan green pit viper bites in Deniaya, a clinico-epidemiological study. So you all know Sri Lankan green pit viper is an endemic species to Sri Lanka, and we have limited number of studies and published data on green pit viper bite and envenoming. 24 green pit viper bite victims were studied, and all cases were daytime bites, despite green pit viper being a nocturnally active snake. This green pit viper is nocturnally active, but almost all cases reported in daytime, because people who are doing tea plucking can get green pit viper bite accidentally, because totally camouflaged snake. So they accidentally touch the snake and can get bite and envenoming, but this is active in night, right? So 16 patients were bitten while they were working at tea plantation, significant number. 67% of studied patients were bitten while they were working in tea plantation. And commonest bite site was hand, it was 42%. And you can see this picture, the first picture on the left-hand side, live green pit viper in plastic bottle brought by one of our big patient. The second picture is a dead specimen of green pit viper. And the third picture is one of our patient who developed extensive limb swelling after green pit viper bite. The fourth one on the right-hand side, you can see a hemorrhagic blister over the bite site of green pit viper. In conclusion, we concluded risk factors were daytime activities in forest and plantation. More cases were reported in May to June during the rainy season. And hand is the commonest bite site. Wearing protective gloves would be a safe method to avoid envenoming. And extensive limb swelling, hemorrhagic blisters, and hematotoxicity could be characteristic clinical manifestations after Sri Lankan green pit viper bite. We have limited studies published. And conservative management is an accepted mode of treatment, as all studied patients recovered without giving any specific antivenom. Let me discuss our second study, which also done at the Deniaya. Hump-nose pit viper envenoming in Deniaya, Sri Lanka, epidemiological and clinical features from a prospective observation study. We studied 83 participants. Also, we collected 52 hump-nose viper dead specimen and identified up to species level. So we identified 39 species of Hypnale sara and 13 species of Hypnale hypnale. And there was no Hypnale nepa was reported in this studied group. Actually, I would like to thank here Professor Arirani. She helped me a lot to do this study, and especially identifying these species up to species level. And she's one of the authors of this study also. So hemorrhagic blisters, enlarged regional lymph node, and extensive limb swelling were reported in both groups. Elevated serum creatinine was not reported. In conclusion, tea pluckers, farmers, and unskilled laborers were risk group. And Hypnale, Sara were reported, and no single case of Hypnale Nepa envenoming reported among the studied group. And most cases were associated with daytime activities. Bites can occur throughout the year, and extensive limb swelling, hemorrhagic blisters, and vascular toxicity were all recognized after envenoming by both species. And there was no fatality or nephrotoxicity. So we have not seen even single case of nephrotoxicity or elevated serum creatinine. And also Hypnale Nepa was not reported in this study. So we can assume the nephrotoxicity may be due to Hypnale Nepa. We don't know what is it. We need further studies just to confirm whether there's a possibility of Hypnale Nepa bite envenoming causing nephrotoxicity. You can see this picture. On the left-hand side, live specimen of hump nose viper brought by one of our patients in a glass bottle. And in the center, you can see another species, dead specimen of hump nose pit viper. And on the right-hand side, you can see a bluish discoloration with the blister formation over the bite site of Hypnale species, right? Brought by one of our patients. Yeah. So this study we presented in several scientific sessions, including CCP, SLMA, and GMA, and we won the best outstation research award for this study. And also 2 papers we published in Toxicon. You all can see online. So this is our 3rd study. It is ongoing study in Mahayangana, epidemiology and clinical features of snakebite envenoming in Mahayangana, Sri Lanka. Objectives: evaluation of epidemiology and clinical features of snakebite envenoming in Mahayangana, Sri Lanka. Methods: prospective cross-sectional observation study at Base Hospital Mahayangana from 20th December to 19th December 2024. It is ongoing study and we have few more dates to complete the study. And offending snakes were identified. We collected dead specimen and live specimen and tried to identify it up to species level. And clinical details were recorded during hospital stay. And results: 145 patients were studied until July, and mean age was 43 years, and standard deviation was 16.84 years. Interestingly, 63 were farmers. So significant number of victims were farmers. 99 offending snakes were identified as 59 hump nose pit vipers, 4 Russell's viper, 2 common crate, 2 green pit vipers, 1 cobra, and 31 medically unimported snakes. Out of 68 of identified medically important snake bites, 59 were hump nose pit viper bites. Interesting. So you get a lot of patients. The significant number of medically important snakes were hump nose pit viper there. It was 86.8. And these are the specimens brought by our patients. Anybody in this audience can identify what is the species? Yeah, this is the trinket snake and called Katakalo in Sinhala, and you can see on the abdomen and tail. So this is trinket, non-poison snake, and this is another species brought by one of our patients. Actually, not bite. This snake wrapped on the patient's finger, and she came to the hospital with this specimen, dead specimen, and this is a large shield tail snake or earth snake. This is, everybody can identify hump nose pit viper. This is another species, the dead specimen brought by one of our patients. Anybody? I'm sure this is simple. This is Indian python juvenile. You can see the quadrants. And then again, you all know this species wolf snake, single broad white rings on the body, and there is no enlarged vertebra. So this is wolf snake. And this species I already discussed, common crate. And I'm sorry, this picture is not very clear. This is another patient brought this specimen. This is rhesus viper. 58.6 bites occurred in the night, very significant. Almost 60% bites occurred in the night. If people use light when they walk in the night, we can prevent significant number of snake bite. And common bite site were finger, foot, and toes. So foot and toes altogether 70%. So if people use appropriate footwear, so number of snake bite can be prevented, especially when they walk in risk areas. So local swelling in 101 patients, hemorrhagic blisters 23, prolonged 20 WBCT 10, elevated serum creatinine 7, neurotoxicity 6, and 2 patients were admitted to ICU for ventilatory support, and 18 were given polyvalent antivenom and 1 died. You can see those 3 pictures, the local swelling over the finger and the extensive limb swelling, and the last one on the right-hand side is hemorrhagic blister over the bite site. In conclusion, snake bite envenoming causes substantial morbidity, mainly from hump-nosed pit viper. Risk factors including walking, outdoor activities and occupation, swelling, coagulopathy, nephrotoxicity, neurotoxicity were reported depending on the species implementing. So we are doing this study and we are going to finish at the end of this month, and we need further evaluation and statistically analyzed data to come to the final conclusion. And it is possible that many snake bites could be prevented by using appropriate footwear and using a light at the night. This study we presented in 2 scientific sessions few months back, CCP and SLSIM annual academic sessions 2024. 2 of my house officers, they presented this study, Dr. Chapani and Dr. Sudharaka, and they are authors of this study, and we won the best poster presentation in SLSIM annual academic session. Let me start second part of this presentation, and snake envenoming. In the world, 2,500 to 3,000 snakes were reported. Of them, nearly 500 are venomous. In Sri Lanka, we have 96 species. Of them, 10 species are venomous. Africa, 430 venomous, nearly. And 5.4 million people worldwide are bitten by snake each year. In Sri Lanka, we have 40,000 snake bites per year, and nearly 100 deaths were reported annually. Snake bite envenoming is a neglected tropical disease, which was announced by WHO in 2017. You can see this picture. This picture is the first volume of Oxford textbook of medicine. When we were registered, we used this book. And you can see the author of one of the editor of this study. This book is Professor David Worrell. Most of you know about sometimes. So he's the world author of snakebite. He did extensively studies on snakebite, especially in South America, Africa, and even Sri Lanka and a lot of Asian countries. So he published more than 1,000 papers on snake bites, but he selected Sri Lankan Tirpolanga for the back page of this volume. Then you can understand the gravity of snake bite in Sri Lanka and the venomous snake. What is this venomous snake? Sri Lankan Tirpolanga or rhesus viper. So that's why I just picture use and discuss. And the medically important snake in Sri Lanka, I'm not going to discuss. Everybody know what are the medically important snakes. Previously, your historical classification is highly venomous, moderate venomous and mildly venomous snake. Now this classification is changed. According to the WHO classification, they recommended to classify medically important snake and medically not important or medically less important snake. So we have 10 species of medically important snakes in Sri Lanka. Cobra, common crate, Sri Lankan crate, Russell's viper, 3 species of hump nose, Merum's hump nose pit viper, Sri Lankan hump nose pit viper, lowland hump nose pit viper, and then saw scale viper, green pit viper, and Sri Lankan keel black or keelback or blossom crate. That species now recently recognized is a medically important snake. You can see this slide. First reported case of systemic envenoming by the Sri Lankan keelback. The paper published in Toxicon. I just tell the scenario. This is snake. You can see the head is orange color with orange patches on the gray black background. This species is endemic to Sri Lanka. Balanopis silanensis. The same name is Rhabdopis silanensis. And a photographer, he was handling this snake to take photograph, and accidentally he was bitten by the snake. Patient was collapsed with low blood pressure, faintishness, and patient admitted to the hospital, and there was incoagulable blood also. So then we recognize this is a venomous snake or medically important snake. After that, we consider this species also as a venomous snake of this country. And low medically important snakes or not important snake, cat snake, Marpila, Sri Lankan coral snake, wine snake, dog face water snake, a lot of snakes, and flying snake. We have 93 species. Then let me to discuss and which may help for the identification of snake briefly, and what are the important facts I will discuss. Caution: don't handle live snake. Even if apparently dead, they may be capable of a reflex bite. How can you differentiate land snake from sea snake? You can check the tail. So the tail is cylindrical, circular in cross section, that taper to the point, that is a land snake. So if tail is paddle shape, flattened side by side for the swimming, that is sea snake. So I'm not going to discuss sea snake because we have very rarely sea snake poisoning, the envenoming in this country, and most of the cases are land snake poisoning. Head is very important to differentiate the snake or identify the snake. Head shape can be triangular with a well-defined neck or oval with an ill-defined neck. So triangular head or oval head. We'll discuss later. Then scales on the head. So heads can be covered with small scales similar to those covering the body, or covered with enlarged scale quite different from the body scale. You can see on the head, large scales you can see, which help for the identification of the snake. And everybody know vertebrals. Vertebrals are enlarged or not. If you see vertebrals, most snakes have equal size scale on the upper part of the body. The crate, however, have enlarged midline or vertebral scales. You can see in this picture. And if you see enlarged vertebral, so the species could be a crate. So also scales on the underside of the tail behind the bed are termed as subcaudal scales. They may be divided or undivided. So if you see undivided scales could be crate, if divided, maybe non-poisonous or maybe cobra. So also the pit vipers have a pit between the eyes and nostril on both sides. That is called l'oreal pit. That is small gadgets which help for the stimulate the temperature. And triangular shaped head, well-defined neck. If this snake has the l'oreal pit, so that is pit viper. If no, the l'oreal snake, then pit vipers. Brown color, head covered with large scales, right? hump at tip of the snout. That is hump nose pit viper. And you can see brown scales, brown snake, and the large scales on the head, shield-shaped scale, and that is the hump nose viper. In Sri Lanka, we have 3 species: Hypnale thara, Hypnale nepa, Hypnale hypnale. So singular term used for this is the Punakatua or Polontelissa. So when we publish paper, the author so asked us what is the meaning of the Punakatua and Polontelissa. Punakatua, you all know. The Punakatua, so the gangrene, no. So you can see necrosis of the bite side. The viper shaped head, so we say Punakatua or Punakatua is that. Then they ask what is Polontelissa. So what is Polontelissa? Anybody know meaning of Polontelissa? Yes, Polontelissa means, Polong means that, you know, the triangular head. Telissa is Tolaisi. So then term came as Polontelissa, right? So you know that hump nose. So that is the meaning of Polontelissa. Then we gave explanation for the publication, right? So this is a green pit, green color, head covered with small scales, green pit viper. The head covered with small scales, and now difficult to identify the snake because this blackish corrugated appearance on the body. And I think you know this species. Brown color, brown patches are there. Looks like hump nose viper, but there is no hump. And also there is no loreal pit. If you see this snake, it's a very elongated snake. So this is simply say cat snake, or this is cat snake, Mahapila. We have different species. So identification is not difficult because there is no hump, there is no loreal pit, and this is an elongated snake, very long snake. So that is one, you know, morphological feature help to identify Mahapila or cat snake. And mildly poisonous. I think you know this species, triangular head, short tail, and the scales on the head is very small, similar to the body scale, and characteristic bird's foot mark on the head. You know what is bird's foot mark? When birds work on the ground, they have 4 towers, and you can see this the marks on the ground. So that is bird's foot mark, and that is there. So this is, you know, so scale viper. Bird's foot mark on the head, so scale viper, highly venomous, and small scales on the head. Now short tail, triangular head, inverted V on the head, and 3 longitudinal rows of brown patches or rings, and this is process viper. Yeah, sorry. So yes, oval shape head, and the neck is not defined. So it could be venomous or non-venomous snake. And if you see these pictures, something wrong here. Yeah, you can see subcaudals are divided and expandable hood, and you can see spectacle marks dorsally, and ventrally you can see 2 black spots. So not difficult. This is very highly venomous cobra. The subcaudals are divided, right? And then what is this species? If you see enlarged vertebrals, so this is crate, right? So we in this country we have 2 species, the common crate or Sri Lankan crate. If you see the paired white rings, that is common crate with the enlarged vertebrals, subcaudals also not divided. And if you see this snake, the white rings, vertebrals are enlarged. So this is the Sri Lankan crate. Both species are highly venomous. Non-venomous snakes, let me discuss very briefly identification of few non-venomous snakes. I think you know what is this. So triangular shape, very large snake. The patches are quadrant shape. So this is python, Indian python. And what is this? Very commonly you can see the very long snake, large eyes, fast moving, can swim, can climb trees. So this is rat snake. And what is this? So there is no loreal pit and no loreal pit, and this is the green color, luminant color species. So you know, I had to love green wine snake. This is another species, non-poisonous. This is called buff stripe keelback, Ahara. You can see this the yellowish brown lines on the abdomen up, continue until the tail. And two species of flying snake, Malcaravella, and not difficult because it's a very beautiful and characteristic morphological features are there. And ornate flying snake and Sri Lankan flying snake. I already discussed this species. This is common species reported in my younger year. This is trinket snake. People kill this snake and come with the patient. And in the neck, on the neck, you can see short, narrow black stripe, and then the brownish color white line on the dorsum of the abdomen until back until the tail, at the end of the tail. So this is trinket snake or katakalua. When they open the mouth, you can see black color. So that is why it is called katakalua. This is again, you have seen haldanda or common brown tree snake, characteristic color and different appearance is there. And two species of wolf snake, there are several species similar to crate, but if you see carefully, the single lines are there and there is no enlarged vertebrals. And also, if you see these lines laterally, it divides into two. So that is wolf snake and non-poisonous vertebrals are not enlarged. This is not difficult. That is Sri Lankan pipe snake, the Patnaya, and the black, white, and the brown, the quadrant-shaped patches on the dorsum and ventral. And this is Deer Nayao, the keelback water snake, and characteristic morphological features are there. This is also called boy's rough-sided snake. The color is very helpful for the identification. This is called Le Madilla. It's a reddish color one. So Le Madilla or boy's rough-sided snake. And this is, I already discussed this species. You all know, right? So basically cat snake or mapilla, elongated snake with the large scales on the head and the brownish, similar to maybe hump nose, but there is no hump nose and the no loreal feet. So elongated, very long beak snake. Yeah, let me discuss few slides, clinical evaluation and snake bite envenoming. I'm not going to discuss more this slide because of the time factor. And you also know that fang, there is a venom gland, and also a lot of toxins are there in this venom gland, they secrete. Then clinical manifestation could be no signs to death. So clinical evaluation of snakebite envenoming, when patients come to you, emergency department, we do triage and then stabilize the patient, ABCDE approach. So you have to correct ABCDE and after triage, then look for the local effects and signs of neurotoxicity, signs of coagulopathy, and signs of nephrotoxicity or myotoxicity. So different species cause different clinical picture after envenoming. Yeah, this is, we should know, 20 minutes whole blood clotting test. Very simple test. How can you do it? We collect 1 milliliter of blood from the victim and keep 20 minutes without shaking. At the end of the, you have to collect this blood into the glass tube and keep 20 minutes without shaking. At the end of the 20 minutes, you see whether there is clot or not. If clot is there, the clotted and patient is not envenom. Or if there is no clots, that is incoagulable blood and vascular toxins are there. Summary of the clinical manifestation, you all know rhesus viper bite can cause local effects, coagulopathy and neurotoxicity. All sort of toxins are there. So even rhabdomyolysis. So that's why that Professor Warrell also, I don't know, but very highly toxic species, and you can see the back page of the first volume of the Oxford textbook. And then cobra, they have local toxins. I discussed the case just after the bite, severe local toxicity. Now patient in the ward with a large wound, and also neurotoxicity. Patient did not develop neurotoxicity of our patient because immediately we gave antivenom for that patient. And crate, only neurotoxicity. Sow scale viper, hump nose, green pit viper, you can see local effects and coagulopathy. CNX, usually myotoxins. First aid, what you want to do? Move the victim to the safety, reassurance. And you have to reassure, we have antivenom and we have emergency treatment. Remove constricting cloth, rings, bracelets, bands, or shoes. And you should immobilize the affected limb. You have to transfer patient immediately to the hospital where emergency treatment available and antivenom available. And avoid the many harmful and time-wasting traditional first aid treatment. Paracetamol you can give for the pain, and a tight tourniquet should never be used. This is the antivenom available in our hospital, imported from India, polyvalent antivenom. And for polyvalent antivenom, you can use for cobra, rasa swiper, common cratons, or scale bite. Should be commenced as soon as possible following the detection of systemic envenoming. Important point. If your patient develops systemic envenomation signs, immediately you have to start antivenom. This is another important point. Antivenom should be administered for local envenoming. Should not be administered for local envenoming except cobra. So you use antivenom for systemic envenoming only except cobra. Cobra bite, you can use antivenom for local envenoming also, right? And this is the picture I show you earlier also, one of our patients, and cobra bite and causing significant gangrene. It is never too late to give antivenom, provided the indications are present. If your patient come late even with the systemic envenoming system, you can start antivenom. And greater vigilance and more frequent 20 WBCT are needed for the monitoring, and early detection and vigorous treatment of anaphylaxis is to be very important. And this is the management algorithm I'm not going to discuss because already I discussed most important facts. And antivenom administration, few facts. Pre-medication with low-dose adrenaline given just before the commencement of antivenom to prevent or reduce reaction is recommended. We can use subcut small dose of adrenaline, 0.25 subcut injections, especially if patient is having allergic and asthma history. Pre-medication with antihistamine and hydrocortisone is not advocated. Also 100 to 200 milliliter or more of Indian poly-specific antivenom in 400 milliliters of normal saline infused intravenously over 1 hour. That is what we are doing. And in cobra and crate bites, usually one antivenom dose is adequate. And in rasa swiper bite, you may need 20 to 30 ampoules, and also you may need to repeat antivenom after 6 hours. And the high risk of anaphylaxis is not uncommon. So we have to treat anaphylaxis immediately if you detect any anaphylaxis reaction for the antivenom. Otherwise, patient will develop a lot of complications. Supportive therapy, tetanus toxoid, and you have to update tetanus status. Fluid management may need sometimes blood product transfusion, antibiotics, surgical care, dialysis, ICU care. Those are the supportive treatment. Prevention of snake bite. Very quickly, I discuss this slide. Avoid the snakes entering into the houses. Use the light and use appropriate footwear. Clear heaps of rubbish and building materials from the houses. Keep gases short or ground clear. Listen to the wild animals. You know that even domestic animals, they call if they have seen animals, the snakes. So you can, they warn. And yes, that is mostly my presentation. And let me finish my presentation with this summary. Snake bite envenoming causes substantial morbidity and is a neglected tropical disease in Sri Lanka. And our small studies, we did epidemiological and clinical studies at the periphery, emphasize snake bite envenoming is an important health issue that drives research focused on identifying new clinical patterns, improving diagnosis, and understanding epidemiological trends to enhance prevention and treatment strategies. Especially registrars who are working in this hospital, if you are interested, the snake bite is a very good common topic for research and study. And snake identification is important for the evaluation and management of envenoming. significant number of snake bites can be prevented by using appropriate footwear and the use of light in the night. And these are my references, few references. And thank you. And this is a picture of Mahayangani, very beautiful Sorobora weather, but a lot of snake in surroundings, right? So conserve what we do, conserve snake while we safeguard ourselves from them, because snakes are very, very important to maintain biodiversity. Thank you.